Well, thank you very much for coming, everybody, and thank you for inviting me to speak today. I would just like to say that what's happening, although as a virologist, being in the middle of a sort of once in a century global pandemic is interesting and fascinating, is what's happening in this country is an absolute tragedy. And it looks as though we are actually going to get to a death toll of at least 100,000. And that's every single one of those people is someone's wife, grandfather, cousin, best friend from work, colleague. It's just an absolute tragedy. So the fact that we've actually got vaccines and that they've actually managed to develop safe and effective vaccines so quickly is really amazing. It's a really amazing feat of science. So that's what I'm going to talk to you a little bit about today. So with apologies for those of you that know about this already, I'm going to start with what vaccines are actually for and how they work and what they do, and then build up to the COVID vaccines. So if you know some of this already, please just bear with me, because I'm assuming that not everybody does. So the aim of a vaccination is to give the patient a weakened form of the infectious agent, whatever it might be, so that it can mount, so the person can mount an immune response without actually getting ill. And so that's what we're actually trying to do with vaccines. And it works in different ways because there's different sorts of vaccines, and the different sorts of technology behind them and different theories. People along over the years, people have different theories about how to do this most safely and most effectively. But of course, the thing I really like, and I'm sure you probably all know this, but I'm going to say it anyway because I just think it's really interesting, is that because the original vaccine was the smallpox vaccine, and that was kind of came from wasn't really a weakened version of the smallpox virus. It was a slightly different virus that when you responded to it, it gave you cross protection, and that was the cowpox vaccine. But of course, language scholars will know that in Latin and many, and in French and Spanish and so on, the word for cow is vacca, and that's where vaccination comes from. And I know you all know that, but I just think it's really interesting, and I think people just forget that. Anyway, so the types of vaccine that you can have is get the virus and then somehow alter it so that it's safe to give it to the person. So there are some versions where it's kind of like a weakened version of the virus. And there are others where you've got the virus and you sort of pickled it, you sort of killed it. And so with the weakened version of the virus, it should go through its normal life cycle, and then you will make the full gamut of the immune response that you would normally make, but hopefully without getting sick. Although obviously sometimes you do get a little bit of side effects from vaccines, just because you put a foreign agent into your body, you'd hope your body would notice that and do some sort of a reaction. But you shouldn't get seriously ill. If you put the killed whole virus into the body, it will make some kind of reaction, but it might not be the full suite of antibodies and cellular response that you might want, but it should cover you for a bit. So that's the basis of the influenza vaccine, for example. It's a whole flu virus which they've pickled, and so that's one of the reasons. It's not the only reason, but that's one of the reasons why you keep having to have repeat doses of it. The other thing you can do, which is a bit safer, is to take the bit of the vaccine, bit of the infectious agent, which is the bit that you really want to make a good response against. So in viruses, it's the bit of the virus that binds to the host cell and gets inside and starts growing and dividing and doing its thing. And if you can just get the genetic code for just that thing, and then fool introduce it to the body in some way, fool the body into making that, just that one little bit of the agent, and then you make an immune response against it, then that will give you the protection. And because we introduce these bits of genetic material inside some other form, the body will notice that, break it down, and so it's perfectly safe, and you've made a targeted response. And so that's the idea between those, and those are called subunit vaccines. So those of you that had the hepatitis B, Energix B vaccine, for example, I expect lots of you have had that. That's a subunit vaccine. They've put the little bit of genetic code for hepatitis B in a yeast, and a Saccharomyces, actually, sort of baker's yeast. So it's perfectly safe. And the other thing, which is a much more experimental thing, is to get the genetic material of the organism and just inject it directly into the bloodstream, and then that should then get inside you and will start growing and producing just a little bit of the organism that you can make an immune response to. And again, it's to just take a bit of genetic material on its own is a bit risky. Kind of technologically, it's not risky. It's not unsafe. It's just technologically a little bit risky. But again, your body will notice it. The thing won't last for very long, so it should be a lot safer than giving like a whole virus or a whole bacterium. So that's the theory behind those. So then moving on to which of those technologies have we used for the SARS vaccine so far? They haven't, luckily, probably not surprisingly really, they haven't gone for a weakened version of the SARS-CoV-2 virus in any of the vaccines. They're in any sort of trials. But some people have gone for the method of getting the virus and killing it, and then making that your whole that's the basis of your vaccine, because that's a tried and tested method. We know that's going to work. Well, we assume that that's going to work because we know how to do that. So there is one of the Chinese vaccines, I think it might already be being through trials and be in use, produced by a company called Sinovac, is actually based on the whole virus pickled, and then gives you the chance to make your immune response to whatever bit of the virus you want to. There's one which has been developed in Europe by a company called Valneva, which is going to be made in Livingston in Scotland, but I think it's an Austrian company, which they're expecting it to be ready to go into trials in March of this year. So it takes a lot longer to actually produce the vaccine, put it through the initial safety trials before it can actually go into clinical trials, which, but there is, I mean, I'm not sure whether in the end, that might be the one that wins the race for the long term, if we do need a vaccine in the long term, because there are lots of sort of technical reasons why that will be a good one to go for in the future, but it hasn't even been, ready, it's not ready yet. Now, the idea of putting the subunit vaccine, the idea of putting the genetic material into some kind of a carrier, that has taken off. And we do have some vaccines against viruses which do work that way. So the Oxford AstraZeneca one, that's how that one works. They've got the genetic code for the spike protein, which is the sticky out bit that you see on all the pictures on the news. They've put that into a safe, harmless other sort of a virus, and then they stick that into you, and then the virus grows and divides, makes the spike protein as part of its growth and division. And then the idea is you make an immune response to the spike protein. Of course, although it's a safe virus, the Oxford one is a chimpanzee virus. Your body is still going to notice that, and it's going to break it down, and so it's not going to last inside your body at all. It should just hopefully last long enough to make the protein for you to make the immune response. And there's also the Russian one, the Sputnik 5, is also based on very similar technology. It's a slightly different virus vector, slightly different carrier, but it's the same idea. And there aren't all that many that are virus vaccines that work that way, but there is one that was approved for use last year. That's the Ebola vaccine, which is also based on the same sort of technology. So that's kind of quite new and innovative technology. But before we started this, we did have a few vaccines, virus vaccines, that were based on that technology. So although it was a bit of a long shot to see whether it would work, and also it's still amazing to me that they've managed to get through all the clinical trials this quickly. It wasn't, completely brand new. The idea of sticking a bit of genetic material inside a person is not something we've ever done before. The idea of DNA vaccines always comes up when you're talking about vaccines, and all the clever people and lots of lectures I've been to, the clever people think, oh, this is the next big thing, is get a bit of DNA and basically sort of staple gun it into somebody's arm. That was the idea, but there aren't any. So the Pfizer-BioNTech and the Moderna vaccine are based on getting a bit of the genetic material of the virus and sticking it into someone's arm. This is kind of really cutting edge. It's really new. And therefore it is really, really exciting that it's actually working, because it was a really, really long shot. And so I always thought, well, one of the reasons they did it is because they could get there more quickly, which is what they have done. But of course, because of the nature of it, it's just a little bit of virus just hanging around on its own. And that's why it has to be kept frozen for as long as possible. And I'm not 100% sure why one needs -80. The BioNTech one needs -80, and the Moderna one you can get away with -20, which is like a -20 is your normal home freezer. I'm not 100% sure the difference. It's the way they've made the preparation, but nevertheless, that is just, it's phenomenally. It's just amazing. And so, as you know, those three vaccines, the Oxford, the BioNTech, and the Moderna, have been through their phase 3 clinical trials, and they've been approved for use in quite a lot of places in the world now. The Sputnik 5 one is in use in Russia. The whole killed virus one is in use in China. So there's quite a lot going on. And if it turns out that the immune response to one of them doesn't last quite as long as we would hope, then I'm hoping that one of the other ones based on the more old-fashioned technologies will come up from behind and potentially take over. And it might, I don't know, I'm speculating, but I think if we unfortunately do get to the point where we have to have annual jabs for this thing, we really, really ought to be able to get rid of it. We really ought to, but I'm not sure that we will, or we won't do it in as a shorter time scale as I would really like. So if it does turn out we need to have annual sort of vaccinations, mass vaccinations for the next year or two, it may well be that the killed vaccine will just turn out to be more feasible and actually might work better. Nobody really knows. So, and it's just interesting. So vaccinations are one of the tools in the toolbox to try and get this pandemic under control and try and stop the transmission of the virus. It's not the panacea on its own. It's not the magic bullet, or what is it supposed to be, moonshot or whatever. It's none of those things, but it is going to help us. And one of the things we expected to help with is preventing people getting serious COVID. So if you've got a little bit of an immune response from the vaccine, you should mop up some of the virus when it gets inside you, and hopefully stop you from getting the serious illness that puts you in hospital and in some cases, unfortunately, kills you. We really want to stop that happening as far as we possibly can. We would expect that if people have the vaccine, they would be less likely to get that are less likely for the virus to grow and develop inside them and then transmit to other people. But of course, what we're seeing, even the report that was reported today from the survey of healthcare workers where they've been following up the ones who've made antibodies, some of them in that study did actually get COVID and did actually produce the SARS-CoV-2 virus inside them and did get it to the levels that could be transmissible from person to person. So the fact you've had the vaccine does not necessarily mean that you're going to be in a point where you're not going to be transmitting it from person to person. But the more people have had the vaccine, the less chance there is for the virus to pass from person to person, along with all the other public health control measures that we're putting in. So it's going to be part of the tools in the box. And the idea is to get us to the point where a sufficient proportion of the population do actually have some kind of antibody, be it from natural infection or immunity. Probably, I think people who've had natural infection and a vaccine will probably have quite strong response. That would be quite good for those people. And for the rest of us, if we've had the vaccine and the virus, while the virus is still circulating, that vaccine immunity will be boosted by the fact that we keep being introduced to the actual virus. And it pokes your memory and makes it a bit, every time you see the virus again, your immune response is a little bit, is strengthened. So, for the next year, hopefully by the end of this year, everyone's had the vaccine. They may or may not have come into contact with the virus as well. And we should have sort of, reasonable level of immunity. By the way, of course, we've got to get that level of immunity to everybody in the whole world. So, before we can really get this thing under control. So that's another thing. I don't think we're busy focusing each country is busy focusing on their own country, but we've actually got to make sure that it's a global effort. And so the other thing which is interesting to think about, which we're thinking about in this country, is who should be prioritised for the COVID vaccine. So I know that the government policy and the medical health professionals policy is to vaccinate the most vulnerable, the oldest and the sickest at the moment, because those are the ones who are most likely to get into hospital, most likely to have very serious illness. And so that's good for the protection of those people. As Kate mentioned, I do a lot of media, and I often get asked to talk about various aspects of COVID at really quite short notice. And yesterday I was on a radio, I can't even remember which radio it was. I do a lot of BBC local radio. Anyway, they asked me about customs. I was Radio London. They said, oh, customs. And I didn't even know what they were going on about. But it turned out that the customs officers on Monday were going, we should have the vaccine first because we're the ones who are making sure that the supplies get through from Europe, food supplies and everything. And then the teachers are saying, well, we should have it first because we're keeping the children in school and everybody wants it first. So it's managing people's expectations is actually quite tricky. I'm not sure how well everybody else thinks that's actually going in terms of communication. And the other thing about communication is the idea of the vaccine schedule. So changing the vaccine schedules, having started the program and said, right, you've got to have these 2 doses and they've got to be within 3 weeks of each other, then suddenly deciding they were going to change that. The scientific basis for changing that one, for the Pfizer one, I'm not sure about it. I mean, I know that people like Chris Whitty and the top public health doctors, I'm not a medical doctor and I'm not a vaccine specialist. So those people, they have said that they're comfortable with doing it, and the Joint Committee on Vaccination and Immunisation are comfortable with doing that with the Pfizer one. Although I say a lot of people do seem to have had both their doses of the Pfizer one, because you can't mix and match. So once you've started on the course of the Pfizer vaccine, you have to finish it. So I think they're probably giving people their second dose that way. With the Oxford one, they have actually done some work. Some of the studies did include waiting for 12 weeks, and they seem to be saying that actually your overall final response is better if you do wait for 12 weeks between doses. So that actually might turn out to be quite a good thing overall in the end. But I do think that the way it's being communicated to people
I'm sure some people have been confused and a bit distressed about that, but I don't think you should be. I think we should be able, we do trust the doctors. We should trust the doctors. But I think that public confidence in the whole control program is something that we do have a problem with this at the moment in this country. Anyway, so I'm hoping that's what I was going to say. I was hoping that gives you some food for thought and some discussion points, and I will happily take questions. Vaccinations are one of the tools in the toolbox to try and get this pandemic under control and try and stop the transmission of the virus. It's not the panacea on its own. It's not the magic bullet, or what is it supposed to be, moonshot or whatever. It's none of those things, but it is going to help us. And one of the things we expected to help with is preventing people getting serious COVID.